Welcome to the Birth Lounge Podcast, an empowering space for expecting and new parents to hear candid conversations with experts, support your mental health, and learn the tips and tricks that thousands of parents have used to craft their ideal birth. We will answer all of your questions, the scary ones and the weird ones, to help calm your fears and feel confident going into your birth. I'm going to help you redefine what birth and motherhood looks like and how to embrace your journey. I've intentionally crafted a list of experts to help you navigate pregnancy, explore your birth options, and plan for postpartum so that it can be a time of soaking in your tiny human. We're going to go there on all the hard topics so that you can dive deep into finding your confidence and freeing yourself from fears around birth. With over 10 years of experience in family education and a master's degree in human development and family studies, I created this podcast as a way to share the resources parents need to make educated and informed decisions about their care in pregnancy and childbirth. This is a birth community driven by evidence-based information and research in hopes to help you explore your options, understand your rights, and know what choices you have along the way when it comes to birth and beyond. I'm your host, Hee Hee. Now let's get to the good stuff. Amanda, welcome to the show.
Thank you. Thank you for having me.
I'm so excited to have you here. I'm very, very excited for this conversation. Our listeners know that I grew up in Mississippi. Mm-hmm. They know that I grew up right outside of Hattiesburg. And I live in Boston now, but I talk a lot about Mississippi because our birth stats here are really bad. Mm-hmm. Birth here is really hard on people. Mm-hmm. It's really hard to find good care. Mm-hmm. A lot of our state is filled with maternity care deserts. And so a lot of women are having to drive hours and hours to get care that they need, right? Mm-hmm. I think that it's really hard to find providers too that treat you the way that you want to be treated. When I hear stories from people in Mississippi, a lot of times women feel neglected by their doctors. They feel dismissed. They feel like they're not being heard. And I know that's a national problem, but I think because Mississippi is so special to me, I think it hits a little bit different for me to hear that in our own state. So I'm very excited to have you on the show today. And I want to cover what midwifery care looks like in Mississippi. I want to cover how legislation either hurts or helps that. And then I'd also like to talk about how women can really take control of the decisions that are made in their pregnancy, specifically in the state of Mississippi. So to start, let's start with the credentials of Mississippi midwives. Who is a midwife in Mississippi? What kind of credentials do they have? And what do consumers need to know about choosing a home birth attendant?
Okay, so that's a little bit complicated, and it's not a specifically Mississippi problem. It's like nationwide that credentials can vary from state to state. So in Mississippi, I guess we should start with there are two types of certified midwives. There are certified nurse midwives and certified professional midwives. So certified nurse midwives are usually RNs or BSNs, nurses that go to 2 additional years of midwifery school. It's about the equivalent of a women's health nurse practitioner, but usually they do have privileges in hospitals or they work in clinics. So they do most of their training and do their work in the clinic or hospital setting. Certified professional midwives do all of our training and most of our work outside of the hospital system. So again, it varies from state to state, but in most states, CPMs work outside of the hospital. I don't know of any hospitals in the United States that have CPMs on staff. So we're almost always in freestanding birth centers or in the community doing home births. In Mississippi, so we don't have any current regulations on who can call themselves a midwife. I guess that's the tricky part here is that we have lots of women practicing in the state who have been here for years and who are very competent and do a really great job without credentials like certification, being a certified professional midwife. Sometimes you'll hear these midwives called direct entry midwives. Sometimes they're called traditional midwives. Sometimes they like to be called traditional birth attendants. Yeah. There's a lot of different names. So that kind of makes things tricky when consumers are looking for that. So I guess the easiest way to remember is the certified professional midwife is a national certification. Okay. And most states that license or regulate out of hospital or home birth midwives require that certification to be licensed in the state. So most require CPMs, not all, but it's a national standard, and it is a national, I guess, it's entry level, a starting place, but it does level the playing field. And to earn a certified professional midwife, that certification, usually you complete an education program. Again, this is where things get really complicated because some states require an accredited program. There are several accredited midwifery schools in the United States. The problem that I see with some of these is that most of them are not regionally accredited. So you're like state universities won't recognize, like credits won't transfer to those, or if you were to go to any other higher level university, sometimes they don't transfer. That's important to look into your state's regulations or requirements for becoming a CPM. Some states don't require a specific education program, but most people choose to do one.
You want to have the credentials to be able to share with your clients, like, I am certified, I do know what I'm doing, I'm qualified. So in the state of Mississippi, CNMs, so someone who's already been a nurse or an RN, are they allowed to practice outside of the hospital at home births?
Not that I'm aware of. I'm pretty sure that they are not allowed to attend home births outside of the hospital. Again, that would be probably a question that we would ask one of them. But as far as I know, that it is illegal for CNMs to attend births outside of the hospital. And one of the really unfortunate parts in Mississippi is that we only have I think 2 or 3 hospitals in the entire state that have midwives on staff. And I know, listen, I'm a little biased. I'm a midwife, so I believe
I'm a little biased too.
I believe in midwifery care, and I believe in the midwifery model of care. And I know it won't change everything, but I do believe that, especially in somewhere like Mississippi, midwives are part of the solution. Midwives make sense economically, like from a financially, from a public health care standpoint, they make sense. It's really sad that we have so few nurse midwives working in Mississippi because a lot of hospitals won't hire them. So for me personally, I'm a Mississippi native too. I grew up right outside Jackson, which is our capital, and met my husband and fell in love in Hattiesburg. So that Hattiesburg is my home, but I actually moved to Colorado to do my midwifery training. And people, of course, we lived in Colorado Springs. It's beautiful on the Front Range of the Rocky Mountains. And when we would tell people that we were moving back to Mississippi, they would be like, wait a second, you're leaving Colorado to move to Mississippi? And I was like, I know, but Mississippi needs midwives so desperately. They need me. Like I think there were around close to 20 midwives practicing outside of the hospital system in Colorado Springs, in my town that I lived in, Colorado. And I know that there are not 20 women practicing in Mississippi right now that are
in the whole state.
In the whole state. Yeah, maybe there are. I don't know the exact number, because that's the other issue. Without any formal like licensure or regulations or anything like that, there's no one keeping up with who's practicing and who's not. And there are no minimum qualifications for who's allowed to practice and who's not. So that's where it can get really tricky with, like I said, just that anyone who decides they want to call themselves a midwife can, and it's really all on the consumers to ask the hard questions. So really, I always tell people when they call me to interview me, if I'm full or if I can't take them as a client or for whatever reason, and I send them to other people, I'm like, ask about their training, ask them how they became a midwife, ask them about their own personal birth experiences, like how many births that they've been to and all of the things, because again, we don't have a minimum like standard set by the state.
Yeah. We find that same problem with doulas, that you don't have to have a training. You can literally just wake up one day and say, I'm a doula, and then you can just be a doula, which I think it hurts the industry. It's hard. It's really hard to be taken seriously when there's no governing body signing off saying, yes, this person is qualified. And in my opinion, these organizations that have made up their own credentials, like DONA, CAPA, Doula International, they're great. But at the end of the day, they fall victim to follow the money. They fall victim to they don't actually follow their doulas. There's no continuing education. There's no actual real support. And so I think it's really hard as a consumer to know who's a good midwife, who is actually credentialed and qualified. And the same thing can be applied to doulas.
Sure. And again, like I said, I don't want to, there are women who are serving like specific communities that are choosing to not pursue certification for whatever reasons. And if that's your personal conviction, I'm supportive of that. But I do think as a whole, I see licensure and like state regulations as a good thing. And I know it's a very heated topic. I will tell you it has like, it's caused a rift between some women practicing as midwives in this state, just because it can be so polarizing, but I view benefits of licensure in that, first of all, I think it protects midwives and consumers.
Yep.
Like it protects us both with some minimum standards there. And that way, it's not that I want to compare midwives to doctors. If someone calls themselves a doctor, or if someone calls themselves a physical therapist, or calls themselves a chiropractor, like there are like national standards and there are state standards. We know that if you are going to someone who is calling themselves one of those professions, that they have met some sort of minimum standards. And we don't have that in the field currently. So consumers could hire someone who maybe is not super competent, or maybe their training isn't
as in depth.
Yeah, as robust maybe as they need it to be, and then this is where it gets tricky because, in home birth, especially, if we're dealing with very healthy moms and babies, like most of the time, the babies are going to just come right out. And I always say the daddy can catch, and I'm sitting there in the corner and I'm just cheering them on, and y'all are doing a great job and make sure everything's okay.
Totally.
Helping clean up the mess and fix them a snack before we leave or whatever. But they hire me so that I can help in an emergency. Really, that's what I'm there for, or a complication. It's the 3-minute shoulder dystocia with the 30 minutes of off and on CPAP that I just had to do at my last birth. Those are the things that you have us there for. And those are the things that I feel like consumers, when they're thinking about hiring a midwife, it's super important to ask about their skills, also about their teams, like, who they're bringing with them to the births, because some midwives in some areas practice like completely by themselves, and they come to births with only them coming. And in the event of an emergency, I'm sure most of the time things go well, but we always want enough hands there for handling complications if we need to. So asking who comes with you, what kind of training those people have, all of those things are super important too.
So who comes with you to your births?
So I like to bring a registered nurse and a trained birth assistant, but everyone who comes with me, we all have neonatal resuscitation training. Everyone is certified in the NRP program, and that is actually the same certification that they use in the hospital setting. It's the American Academy of Pediatrics. We just do additional training in how to do it outside of the hospital system because we don't have the wall unit there. We do the same,
more resourceful.
The same training, same test, but then we also have to figure out how to like fix it up when we're out in the woods somewhere. We do that. We all have CPR, basic life support training, and then we also do regular skills drills as a team. We'll get together and practice different scenarios and what we would do in this kind of situation, and how they can help me as I'm helping the mom and the baby.
So home birth primarily is always low risk people.
Sure.
What would be something that would risk someone out of your care that you would need to have a conversation and say, unfortunately, I think you're better to have your baby at the hospital, even though I know that's not what you want, and I don't want that for you, but you are safer there.
It's hard to just say these specific things. It's more like a case by case situation, and it's definitely looking over women's individual health records, because, and this is where I may differ a little bit from a lot of the medical community, but I don't view like individual things as like a risk factor. BMI is a good example. So body mass index, just because you have an elevated or a low BMI doesn't necessarily mean you're healthy. Like I want to look at your whole person and see what about the whole rest of you? Like maybe your BMI is elevated, but if you're in really great shape and you eat well and nourish your body and exercise and you're doing all the things, your labs look good, everything else, then I don't consider that a risk factor. But the same is true on the flip side. Like I said, you could have a low or normal BMI and eat hot fries and drink big peach all day and be really sick on the inside. And we could see that with labs and there are some situations where we can do a little tweaking with nutrition, and we can work on things and keep you or get you back into the realm of normal and keep you in care outside of the hospital system. But there are some things like certain blood disorders and things like that you might have. Hypertension, if it's just chronic high blood pressure that won't come down, if you're on medication, you would at a minimum need co-care with an OB to be monitoring all of that and making sure that looks good. Of course, things with the baby, certain situations with baby, and this is why I am an advocate for the 20-week anatomy ultrasound. I know ultrasounds can get a bad rap sometimes, and I'm not a fan of overusing for sure, but I do think when used appropriately, they can be really helpful, especially with home birth. A 20-week anatomy scan, I know families get super excited about finding the gender on that scan, but I'm like,
that's not what that one's for.
That's the least of my concern. I forget to to ask sometimes, what is the baby? I don't even know, but we're looking at, me as the provider, I want to make sure your babies, all of their organs are functioning properly. The spine looks good. Everything looks normal on that baby. Because if we were to find something going on with the baby's heart or lungs or brain or something like that, where the baby would need immediate medical care as soon as they're born, then we know that baby needs to be born in the hospital and not at home. And that's something that I want to know. I don't want to be having a baby at home that's going to have a poor outcome because we chose to be at home when we could have been in the hospital and they could have had the care that they needed. And the families, most families feel the same way too.
Yeah. I always joke that our home birth and our free birthers are some of the most educated birthers because they know that the responsibility falls on them. They know if shit hits the fan, they're the ones who have to clean up the mess. Where if you're birthing in the hospital, there's almost this sense of security, whether it be true or false, who's to say, but there's a sense of security of no matter what happens, they'll be able to fix it. And you don't always have that security at home, right? So what are some situations where you might encourage someone to have more co-care, but still birth at home a little bit more than just that 20-week anatomy scan?
Yeah. I mean, I have had a couple of clients that have had something on the anatomy scan with the baby, either with the kidneys having a little bit, like enlarged kidneys is a pretty common thing that we hear. And sometimes they just need a follow-up ultrasound or something like that. I have had a couple of clients that have been on certain medications that they needed to be on throughout pregnancy, something like that. And that's something that I prefer them to see either a family doctor, endocrinologist, OB, whoever the appropriate provider is for that situation, but someone else to oversee that dosage of medication and that kind of thing, just because it's outside. Midwives are experts in normal. So we're really well versed in normal, healthy pregnancies. Anything outside of that, then we need some extra help from higher level care.
What would it look like, I guess, in terms of an emergency? Can you talk to us about a transfer plan? How do you talk to your clients about a transfer plan? What are your boundaries around, okay, now's the time that we should head into the hospital?
Yeah, I feel like I need to knock on wood. but so far, the transports that I have had since I have been accepting my own clients as a midwife have only been for pain relief.
Wow, that's awesome.
They've been non-emergent situations.
Most of them are from home birth.
Yes, but they've been for pain relief. So non-emergency situations. So there's been plenty of time to talk with the family, first of all, and make sure that they're in there. One of the things I talk with clients with, I try to do this at the prenatal home visit. So around 36 weeks, my team and I come to their house and we bring the pool and we show them how to set everything up. And we talk about getting ready for home birth, but we also cover common complications. And I do try to bring it up at the home visit that if we need to transfer, or if the mom is there something going on with her where she feels like she would be safer or she wants to go to the hospital, I try to reiterate, please don't say, I want to go to the hospital or take me to the hospital unless you want to go to the hospital, because I will take you. You're a grown-up adult. I'm going to take you to the hospispital if you say I want to go to the hospital. So if you're just getting to that hard part of labor where we all get, where you're like, I don't think I can do this. I think I'm going to die. I want drugs.
Hey, you're in transition.
You can say,
We're almost there.
I'm like, you can say any of those things. Just please don't say I want to go to the hospital, because I believe that moms have intuition and women can like feel something. Sometimes she might be able to feel something in her body that I can't feel. And if she only has the words, I need to go to the hospital, whatever she has, but we're going to go. If she says that, all bets are off, we're going. Now, if I'm seeing something that makes me think that we need to go to the hospital, obviously, depending on the time and situation, there are a few very rare, just rare obstetric emergencies that we need to go like immediately, and there's not a whole lot of time for conversation, but most of the time we have plenty of time for conversation and we can talk about it.
What would those things be? Like funky fetal heart tones and obviously postpartum hemorrhage. What else?
Yeah, so for complications, is that what you're talking about?
Like,
or are you talking about the emergency?
I guess both. For you as a midwife, what are the things, the situations that are cluing you into, okay, we should transfer?
Yeah, so I would say yes, definitely fetal heart tones. If the baby doesn't sound good and we've tried all of the things, we have a whole list of all the things that we're going to try to help resolve those. Position changes, maternal nourishment and nutrition and hydration. Honestly, sometimes just mom's dehydration can cause fetal heart tones to be funny. Sometimes oxygen can help. That's a little bit we're seeing new evidence that maybe it doesn't help quite as much as we thought before, but I'm
Sure.
also like, probably doesn't hurt anything. So why not, if we're trying all the things,
Totally.
like I said, changing positions can be super helpful. But if we're doing all the things and the baby's heart still really doesn't sound great, then we should probably go. And birth is not imminent, because sometimes the baby's heart doesn't sound super great when their head is like all getting squeezed and they're like almost here. So if they're almost here, it's a different situation. But if they're like not close to pushing and not sounding great, then we would want to go in. Other things would be like maternal vital signs. So if mom's blood pressure is like sky high and not coming down, even if we're doing some things to try to help bring it down, that would be a reason to go in. Fever, of course, maternal fever would be a reason to go in for sure. Yeah, I think those are most common. Really bleeding during labor, other than like bloody show, but like bleeding, active bleeding is not normal, and we should probably go in. And then, like I said, there are some very rare true obstetric emergencies like cord prolapse. We've heard of things like that, placental abruption, and things like that. Really, we would have signs and we would need to go as soon as possibly. Yeah, probably not even waiting on an ambulance. Probably trying to get in a car and go as soon as possible. But again, this is where midwives are well trained in how to handle those kind of situations. Placental abruption, there's not really a whole lot we can do. Cord prolapse, though, we do train on how to handle that, even though most of us have never seen one in real life.
Because they're so rare.
Because they are so rare. Yeah. Those true emergencies are very rare. And again, one of the ways that I explain it to my clients is we have built this sweet relationship over nearly a year of care with you, where I'm seeing you at least once a month in the first 2 trimesters, and appointments are an hour long.
Not 8 minutes that you go to the hospital.
So we're getting to know each other. You're telling me about your family and your mother-in-law and like all kinds of situations. We get to hear all kinds of things. We get to know each other really well, but I also get to know what's normal for you and for your baby. So I always like to bring up like fetal heart tones. The 120 beats per minute to 160 beats per minute is like what's textbook average. It can be anywhere in that range. But like I always use this as an example. If I have a baby that throughout all of pregnancy has been in the 120s, 130s, if they come in for their prenatal appointment and they're running in the 160s, that could still be considered normal. But for me, I'm going to think, that's not normal for this baby. For this baby, exactly. And so that's going to make me want to investigate more. Same as with maternal blood pressure. A lot of my clients, their blood pressure runs really low. So I have some people that are like 90/60, where normal is 120/80. That's like what we say is like the normal for blood pressure. And high is not really, it's not considered high or the lower level of high until we're over 130/90. But if I have a mom who runs 90/60 and she comes in at 120/80, I'm going to be like, what's going on? Red flag. But if I have seen 100 people today and I'm just looking at a piece of paper, I see 120/80 and I'm like, great, she's perfect, and move right along. Midwives, I feel like because we usually have a lower client volume and we have this relationship built with people, and we're really looking at you holistically as a whole person, you and your baby, we're able to pick up complications maybe before they become a full-blown emergency, where we can start being like, why is that like that? And we'll try to do some things to fix it. And then if we get to the point where we've tried all the things and it's not resolving, then that's when we seek higher level care.
Yeah. Now, do midwives carry in any sort of medication or equipment to handle these emergencies? Because I know that for people who are maybe teetering on the line of, should I home birth, should I not? The emergencies are very scary, rightfully, right? No one wants to experience an emergency. What can we expect from our midwives in terms of equipment and medication that you carry to help solve these emergencies?
Right. And this is where it varies from state to state. And for sure, it will vary from state's regulation. So if a state licenses and has regulations for midwives, then they are going to have like requirements, and midwives can, at that point, I guess they could choose whether or not they want to carry certain things, certain medications and that kind of thing. But this is where I feel like, especially in Mississippi, it would be beneficial for us to have some regulations and some licensure, so that we have like a guideline by the state that says like what we're allowed to have and what we're not allowed to have.
Okay, so now I want to talk about labs, because I know that we're all so familiar with labs at the hospital. They obviously have labs at the hospital. What do you offer as a midwife, a home birth midwife, out of the hospital as labs? Can you draw labs? How do you get those run? You obviously don't have a lab here. So what does that look like?
So I don't have a separate room that's a lab, but I do. I joke about my office being like Transformers. We'll just shift stuff around, and like
now it's a lab.
set up our little lab conversation. We do it at home birth. Home birth midwives are pretty good at making something out of nothing and improvising a whole lot. So that's kind of what we do here in the office too. So I actually have an account with Quest Diagnostics.
Okay.
I feel like a lot of midwives do. Lab companies usually work pretty well with midwives as long as we have an NPI number and that kind of thing. So I have an account with Quest and I draw all of our labs here in the office. So I offer all of the same blood work that's offered through like our local OBs and everything. I try to offer everything to my clients that's offered in the hospital setting or in the clinic setting, just sometimes in a different way. Or I offer it all, I give them all the information, and then I do offer true informed consent and refusal if they decide that they don't want to. I feel like labs, though, are one way that we make sure that mom is safe and healthy for home birth. So it gives us an inside look into her body. Again, like I said, like the woman with the lower BMI who eats hot fries and drinks soda all day. She may on the outside be a healthy weight, but on the inside of her body, her kidneys are not functioning well. Her liver's stressed and doing all kinds of things. So those are things that we find out through blood work. And I feel like that's really helpful. I'm a really big fan of labs in pregnancy, first trimester labs, and then again in the 28 weeks, usually around then, and that 20-week anatomy scan to make sure that mom's safe for home birth and that baby's safe for home birth.
Okay, and then what about labs afterwards? Because we're often running labs in the hospital on babies. What kind of labs do you offer for newborns? Newborn screening, jaundice, anything like that?
Yes, and so that's going to, again, vary state to state, depending on their newborn screening program. In Mississippi, our state pays for newborn screen, so it doesn't cost parents a single thing. When midwives start practicing in Mississippi, they just set up through the state, and I have the cards, and I do the newborn screens at their home visit after the birth. So we do that. I also do congenital heart defect screen on the baby, which is really a big scary word, but it's essentially just using a pulse oximeter on their hand and their foot to make sure they're oxygenating evenly and that their heart is working properly. It can be an early indicator of heart defects. So that's something we check for too. I try to offer everything that's offered in the hospital setting for my clients. And if I don't offer it, I have referrals. So one thing I don't offer that's routinely done in the hospital is the hearing screen on the babies. So I don't have the equipment and I'm not an audiologist. I actually have a wonderful female practice. I love to support a woman full audiology clinic here in town that actually has, I want to say 4 or 5 female audiologists. And so I send all my babies over there. Yes. And they take care of them. They actually do I think they said their screening is a little bit more in depth than they do in the hospital. So maybe I think if babies in the hospital fail, they refer to this clinic. They do a very thorough job. I'll refer for things like that. The other thing that is going to just vary from midwife to midwife and I guess provider to provider, but I don't carry the hepatitis B vaccine. That's another thing. And I give parents the information about it. And if they want to do that, I just let them know that's something that they can do with their pediatrician or at the health department. But I don't carry it. But other things,
vitamin K,
erythromycin.
You do carry those.
And they have, like I said, I give them the information. We go over risk and benefits, answer any questions that they have, and then they make the decision on whether or not they want those things.
Sure. And if someone wanted to decline the vitamin K shot, but instead opt for the vitamin K drops, is that something you would talk them through and help them decide?
And they can do it. If they decide to do that, I usually recommend that they have it at birth so that we can go ahead and give it to them, to give it to the baby, because they're supposed to be given like the first dose at birth and then every weekly until they're around 3 to 6 months. So I talk them through the recommendations, but part of informed consent is also letting them know that the oral option that we have here in the state has not been clinically studied the way that the injection has. We often refer, this is where I'm going to always be sending people to evidence-based birth because I'm like, they have all of the great information and you can look into it. But it's just the formula that's available to us here has not been studied the same way.
Sure. So there's just a little bit of risk that you're taking on as a consumer, as a parent.
Sure. Some parents feel that having the injection is also a risk. So it's weighing the risk benefits and making a true informed decision. So them having all the information that they need and doing research. I, of course, provide lots of links at the end of any of my handouts that I give with other sources, and I encourage them to go home and do their own research and let me know what they decide.
I think it's really important that they have a provider that is willing to respect their autonomy, even if that's not what that provider would have chosen for themselves or that's not that provider's clinical suggestion. It is so important. And it actually empowers that parent more to have a provider that says, I trust you to know your body better than I know you, even though my clinical recommendation is a little different than what you're choosing. I'm going to support you in that. And I'll be upfront if I start to see that we're headed in a bad direction or I start to see problems are coming up. That for me is so huge. And I think, unfortunately, that's lost a lot of the times in the hospital system. We see, obviously, we practice mainly in Boston, but we do have nationwide services. We travel for services. And I think that just nationally, that is one of the most challenging pieces when we see people in the hospital, is that providers really struggle to respect autonomy. And I think a lot of it is fear. They don't want to go to jail. They don't want anything bad happening. They don't want the trauma if anything bad happens. But at the end of the day, part of doing no harm is not causing that person trauma because you have forced them into something that did not feel aligned to them after you've given them the true conversation of benefits and risk and alternatives.
And I talk to my clients all the time about, even I care a lot about them and their babies, but no one cares more about them and their babies than the two people sitting in front of me. And I do believe that they're adults who can make their own healthcare decisions. So I'm like, I'm going to give you the information, but at the end of the day, the bottom line is people can have the same information and make different decisions with it. And there's a lot of factors: culture, community, things that they've read, lived experiences. Sure, there's all kinds of things that affect the decisions that we make. So we don't know everything behind that person's train of thought. Sometimes they will share things with me. But again, this is where that relationship is so important, the relationship that I build with my clients, because at the end of the day, if I have a client that has decided to decline vitamin K, if we have a birth that is like complicated, a shoulder dystocia or something like that, where the baby has had just a little bit more of a traumatic birth for the baby, not necessarily emotionally, just like hard physically. And I feel like the baby would benefit from vitamin K. That's something that I'm going to tell them. And they always have the opportunity to change their mind at any time. And I do tell them, because I've been on both sides of this. I have 5 babies, so I've been the birther also, but I tell them, if I'm coming to you again and I'm asking, just double checking, what did you guys decide on vitamin K, or what did you guys decide on erythromycin? I might not have my chart in front of me and remember exactly what they decided. It's never me second guessing their decision. It's just me confirming what they have decided. But also the same is true if there was a situation that came up and now my recommendation has changed, where if I have been okay with whatever they've decided, but then something with my clinical experience lets me know that this baby would benefit from this procedure, or this mama, if I'm seeing something that I'm like, I really would feel better if I think that this situation warrants this XYZ, even if it's something that she already maybe said she was okay with passing on, I would let her know that. And that's where I feel like the relationship helps, because she knows that I know her wishes, and I'm not going to be coming to her and making a recommendation if I already know that she doesn't want it unless it's necessary. Then she knows that if I'm recommending it, and if I'm saying I feel like it's necessary, then she can trust that I might know, or I might be seeing something that she doesn't, or just know of something that might be a reason that it's necessary. So
you're allowed to change your decisions based on new information, right? Doesn't mean you have to. Certainly still decline. But if you have your healthcare professional saying, the information that we have now has changed things for me, and I think my recommendation has changed, you as the consumer can really find comfort in that, saying, all right, I know Amanda would not be recommending this if she didn't truly believe it was going to be helpful and beneficial for me and my baby. Cool. Okay, I want to circle back to transfers. Because that's one of the scariest things that happens, right? When we plan a home birth, nobody wants to transfer. And I think that there is oftentimes some resistance from the hospital. And you and I both know, listeners, you guys know, that sometimes that can impact patient care. So talk to us a little bit about, what do transfers look like, and what are you doing to build that relationship with the hospital staff around here? And what can patients do? What can clients do if they get into the hospital, they have needed a transfer, and they're being treated poorly by the hospital staff, and they're not getting compassionate care?
So I have so far only had to take one client into the hospital since I've been back in Mississippi for 2 years. And I will say the labor delivery experience was beautiful, and they were really wonderful to my client. I was really thankful. So shout out to Forest General Hospital. They were doing a really great job there in Hattiesburg, Mississippi. But so some things that I did ahead of time, though, and again, I know I had the luxury of time because this was we needed pain relief, and we needed a little augmentation here for prolonged rupture of membranes situation. So I called so in Colorado, we actually had a direct line to the physicians. And so we were able to call and speak to the on-call OB. We don't have that here in Mississippi yet. Maybe that's in the future. So I just called labor and delivery, and they actually let me speak. I guess a nurse answered, and then she transferred me over to the charge nurse. So I was able to speak to the charge nurse, and I gave her a full report of what was going on and the basics. I also asked for their fax number so I could go ahead and fax over records. I think that's one thing that is super helpful if midwives can do that ahead of time, is sending over records. And I know it can feel a little vulnerable as midwives to open up and share your records, but it's the best way to be transparent about what has happened at the labor so far, and so that they know what
what they're receiving.
Yes, what's happening. And it makes the transfer smoother for the clients. And really, that's at the end of the day, we need to be thinking about this woman and her experience and what's going to make this smoother. If you go in there if you just show up having not called and not sent a single record, you're showing up with this woman who's not in their system. That's another thing, is a lot of these hospital systems, their clinics even share the same charting, or I guess patient information. I know, like, we have a portal and you just log in and you can see any different kind of provider within like their network or the hospital, and it's all in the same electronic healthcare like record software. So for home birth clients who are coming in from outside of they're not in the system, and so they pull them up and they're like, oh,
we don't know this person.
We don't know it. We don't know what to do with you. Just having simple things like that, like where you can send over your chart. The other thing that's really helpful for transfers is, oh gosh, I don't want to butcher this. Maybe you can link it in the show notes, but I think it's called the Home Birth Summit. They have a 1-page transfer form that midwives can just fill in. I guess you could do it electronically. There's probably a way to do that. I have paper copies of it, so you could just literally write it down. But it's got all of her basic contact information, her age, her blood type, her weight, any relevant health information that they might need right away to know about the baby, if she's GBS positive or not, any complications that she might have had in pregnancy that they need to be aware of. But that's a 1-page form that you can bring in with you. So you faxed over your records, they're getting those. You never know where where does it actually go? And you're like, who knows if it's going to get to the right person at the right time. So bringing in that 1-page paper is really helpful. It's just like at a glance, they can have that and they'll be able to see it. So that's helpful. But I feel like, again, calling ahead of time and giving kind of a background information about what's going on so they know what to expect. They had a room waiting for us. They knew that we were coming. They were really wonderful and very empathetic. Like I said, this mama was not planning on being in the hospital, and it was definitely not her first choice of places to be. And so they were just really, like I said, really compassionate, understanding that her birth plan had changed, and I really tried to still give her a great experience there.
Sounds like you achieved it.
I think like a little bit goes a long way, working with the hospital system instead of trying to maybe fly under the radar. Like, I've heard situations back in the day where midwives and rightly might have been afraid of criminal prosecution or something like that for going in a state that was either unregulated or illegal. So they just send patients in without them coming in with them. And then I feel like patients can be treated really poorly in situations like that. So I went with my clients. I was there with them, and I was able to answer questions and also help her to still advocate for herself. And we had a great hospital birth, just change of location. And she would say that she felt like it was an overall a great birth, even though the location changed. So
sometimes it's needed though, right? Sometimes we get into a situation where we were a great candidate for home birth, and now that new information has informed us differently, and now we need to transfer. I'm a little surprised to hear that sharing your medical records can feel vulnerable, only because I think that if you are keeping good records, shouldn't you feel confident in sharing them?
I would think so. Yeah. And that's why I'm a big fan of charting, and like very thorough charting. And like charting like every single thing. Like my assistants will laugh and they'll tell you I've trained them well to know
patient has pink toenails.
Anytime she changes positions or anytime she takes a sip of water. And you might not think that's relevant information until she takes that one last sip of water, and then she hasn't taken a sip of water in 45 minutes. And we're like, when's the last time she had something to drink? And y'all know, anybody who's ever been in a birth space before knows what I'm talking about with labor land, and like time doesn't exist. It's so weird. So I'm not good enough to be able to keep up with all of that in my head. So I'm like, please chart everything. And then I also have them chart, of course, any relevant like medical documentation that we need, any of vitals or listening to the baby or anything like that. But I also have them chart, sometimes I'll have them chart things that the mom will say, because sometimes she'll make a comment like, I can't do this much longer. And then I always am like, Because I'm like, I want to know how long was it from when she said that to when the baby was out, or things like that. Because those things I feel like are pieces of her birth story and helping her to put that together afterwards. Look, you said you don't think you can do this much more, and your baby was born in 23 minutes after that. Look at you, aren't you strong? I'm like, I just feel like that's helpful for women. So yeah, I'm a big fan of charting like every single thing.
I appreciate your transparency. And I know that I think your clients would feel the same way. I don't know how open you are with your clients about that, but I know that as a consumer, as someone who's considering home birth for myself, I feel a lot of comfort in knowing that not only are you charting so much, but you're more than open to say, here, hospital, this is what we've seen, this is what you're receiving, this is how you can meet us where we're at. And I think that's so crucial.
Yeah.
That's awesome. Okay, let's circle back to the question of if we are mistreated in the hospital and those preconceived notions or maybe some personal beliefs about home birth has impacted patient care from the physicians or the hospital staff. What rights do patients have and who do they call? How do they advocate for themselves, especially in the case that CPS might be called? We've had that happen a couple of times in Boston where we transfer in the hospital that our client chose is not the friendliest to home birth. And so when we get there, from our perspective, it can really feel like they're searching for something to call CPS on, whether that be true or not. If the perspective is that it feels that way.
Sure.
Where do we go as a patient? How do we navigate that? Who do we call?
Yeah. So it's really tricky. I guess like part of the thing I like to remind people is that the hospital is not prison.
Totally.
They cannot force you to be there. They can't force you really to do anything. They can make recommendations, but no one's allowed to do anything to your body or your baby without your permission. So you are really in charge. And I feel like if we can remind people of that you're in charge of your care, I feel like then that gives them some ground to stand on and to really be more a part of the decision-making process with their healthcare team.
Right.
Now, as far as like poor treatment goes, those are things they're almost, I'm sure probably every hospital, but I won't say that just in case there's not definite, but almost every hospital will have a patient advocate that you can contact. So you can always call your hospital and say, I would like to speak to a patient advocate. I feel like my rights are being violated. I feel like when you say things like that, those are like keywords where yes, because hospitals are a business. They are a business and they are trying to make money and they want to make people happy for the most part. So if you're being mistreated or if you feel like you're being mistreated, usually they will try to right wrongs. I feel like most of the time, and that's going to look different in different cases. But yeah, I would say speak to a patient advocate first. Sure. The other thing you can always do is ask for a different provider, whether it's a nurse or whether it's a doctor, pediatrician,
NICU staff.
So especially, I love if you have a pretty good relationship, specifically in labor and delivery or postpartum with your nurse. If you find a nurse that you really love and you can bond with, that's like really helpful. Yeah. And then that way, if a doctor comes in and has treated you poorly or is not listening to you, tell your nurse, like, this doctor is not listening to me, or I feel like I'm being pressured into things that I don't want to. I would like a different doctor, please. Can you please find me one, or can you please document that I'm asking for a different doctor? Who can I speak to about getting a different provider in here?
Because I think a lot of people think, I don't know if a lot of people think this. I think there's a common misconception that nurses work for doctors, but actually they're a patient advocate.
They are.
Part of their job is advocating for you. Now, that doesn't always mean that within the unit culture, that's possible, or that with that particular provider, that nurse feels comfortable doing so. There are obviously outside influences and factors that are going to impact that. But at the end of the day, knowing that your nurse is actually there to advocate for you is really huge.
I think so too.
Yeah. You find a lot of people that come to you that have had traumatic births in the hospital before, and they essentially feel like this is a better option because they don't want to go through the abuse and trauma that they experience in the hospital.
Absolutely. I do.
That's unfortunately. Sad. Yeah. Our team gets hired a lot by medical providers that it's always so funny to me when medical providers, especially if you're an OBGYN or like a pelvic floor physical therapist or a labor and delivery nurse, and you choose the birth outside of the hospital. For me, I'm always like, what did you see in the hospital that has changed your mind so much?
I know. I just recently had to go back because I was thinking, actually, I have a lot of healthcare providers that are clients currently. And I just went and looked, and I think it was 35% of our client base is in the medical field. So yeah, it's true that healthcare providers either see things that are traumatic to them or know that they don't want to be in certain settings, or they also might really feel confident in their decisions or choose alternative
Sure.
healthcare for their birth or for their pregnancies.
Yeah, that's awesome. So I feel like we have covered pretty much all the home birth stuff, the questions that typically pop up with home birth care. Let's wrap up by talking about the legislation in Mississippi. I guess just start. What do we need to know? Because I think there's a lack of legislation.
Sure.
And you've talked about there's some real gray lines. We don't really know who's a midwife. We don't really know the credentials. How's legislation helping or hurting?
Sure. And I feel like we also, a common question that we get often is midwifery legal in Mississippi, or is it illegal? People ask that a lot. And the easy answer, or I guess the quick answer, is that yes, it's currently legal. First of all, women can have their babies wherever they want to, with whoever they want to have them with. Now it's going to, what credentials that person is saying that they have, and vice versa. That's where it's going to get a little bit tricky. But in Mississippi, it is currently legal for midwives to practice. So we have, like I said before, certified nurse midwives fall under the Board of Nursing, and they have regulations that they have to follow in order to keep their license that way. And then everyone else that is not a certified professional midwife, we're all sometimes clumped into the group that are labeled direct entry midwives, which means we just went directly into midwifery instead of using nursing as an avenue to get to midwifery. So went directly into midwifery. Direct entry midwives, though, can also be certified professional midwives. Some don't have certification, and we'll use those letters, direct entry midwife, to identify themselves. But in Mississippi, that's what is not currently regulated or licensed. So we don't have a license there. We are allowed to practice legally, though, because in Mississippi, we have the law that's standing that defines what the practice of medicine is, which is a very long document. I want to say 90 something pages, lots of lines about what it means to practice medicine, who's allowed to practice medicine, what it looks like, all the definitions and everything. And it sums up at the very end of this. It has a tiny little clause that basically says all of this shall apply to all of these people, blah, 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 with the exception of women engaged solely in the practice of midwifery.
So what does that mean? Is that helpful for midwives or not?
I think most midwives would say right now it's more helpful than hurtful, like in that we are allowed to practice without being accused of practicing medicine without a license. But there is some, I would say, some vulnerability here, or just some
risk that you're taking on.
Yes, that we're taking on, because we don't have a license in the state, and we don't have clear regs about what we're allowed to do and what we're not allowed to do. So I know for me personally, I chose to get a license in our neighboring state of Louisiana because they have them and Mississippi doesn't. Because I'm a fan of credentials and things like that. That's what I was looking for when I was looking for a midwife. I know some people are opposed to it, and I'm like, there's a midwife for every woman who wants one. You can find the one that you want, but I like to practice the way I wanted to find a midwife. I licensed in Louisiana just so that I would have that there, like, until Mississippi offers me a license. And then as far as like the way that we practice and our standards of care and things like that, I choose to follow the national standard with the scope of practice set by the North American Registry of Midwives, NARM, that gives the CPM certification. Eventually, hopefully, we will have legislation in Mississippi that both protects consumers and midwives. I think that would be the best thing, and that allows us to practice to the full extent of our scope and training.
So you are pro-regulation, pro-legislation of let's get everyone kind of these base credentials so that no matter what who consumers hire, they can be assured that everyone is coming to you with these basic skills, and then anything that midwife does above that is extra.
Sure. Yes. I think that protects both consumers and midwives. Again, please don't send hate mail. I know I'm going to have people who have differing opinions, and that's okay. Everyone can have their own opinion, But for me personally, just coming from a state like Colorado that has been licensing midwives for a while and has pretty fair regulations, I feel like it's good for everyone. Midwives are much more integrated into the healthcare system in Colorado than they are here in Mississippi. I feel like in order for us to get the state of public health in Mississippi to change, licensing CPMs or direct entry midwives, or I should say, will lead to better outcomes. It'll lead to more accessibility. We can't even talk about accepting insurance or Medicaid or anything like that without a license. We can't talk about being able to open birth centers and things like that without licenses. In order to create more access to care, I think licensure will go a long way for
Which
that.
is super unfortunate in a state that leads our nation in maternal mortality and infant mortality. That is just, it's so crucial. I also think with maybe some national legislation and even starting at the state level, your hospitals will trust you so much more. You'll find much less of a divide. You'll find much less of that skepticism of who is this midwife? What's her training? What is she going to bring into us? I think if everyone had just that basic level of, yes, I have met these requirements, it will help integrate that for sure.
I think so too.
That's awesome. This is an awesome conversation. Is there anything else you want to leave us with?
I always try to, like, anytime I get a woman who will listen, it's a reminder that no one can do anything to you without your permission, and that your body was designed to give birth to babies. And most of the time it works really well, or else there wouldn't be so many humans on the planet, right? And that's from my girl Anime.
Don't forget that birth is a natural event that sometimes needs medical intervention, not a medical event that sometimes happens naturally.
That's right.
I love that. All right, Amanda, where can people find you online? How can they work with you if they're interested in your services or learning more about you?
Yeah, sure. You can go to HattiesburgMidwifery.com. We're also on Instagram, TikTok, Facebook. I had to get my teenagers to help me set them all up, but yes. We're trying to be out there and really getting the word out about midwifery care and improving health in Mississippi. We're really passionate about being a part of the change.
I love that. Okay, know that I am standing behind you and beside you, and I'll lead you. I'll be in front of you if you ever need that. But I'm totally on board with helping the women and the families of Mississippi have more accessible care, have care that's truly respectful of their autonomy and their consent, and really helps to lower our maternal mortality and infant mortality in this state. Thank you so much for tuning in today. I truly do value this community, and I love hanging out with you. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent. It's an honor to be your go-to gal when it comes to preparing for your baby. If you found today's episode helpful, share it with a friend. Share it with someone who could use evidence-based information to help them have an informed and confident birth. I'd love to hear what you have to say and read your sweet words. By leaving us a review, you are helping other expectant mamas and their families find the podcast so that we can reduce birth trauma and improve maternity care in the U.S. one birth at a time. If you're interested in joining the Birth Lounge, go to thebirthlounge.com. If you want to connect with me on socials, you can find me at Tranquility by Hihi on all platforms. Until next time, stay educated, stay supported, stay confident. Bye!